Hello everybody, we're back for part 2 of our acute abdomen lecture. We're going to dive straight into appendicitis, then we're going to review another terrifying illness called the abdominal aortic aneurysm, and then we'll finish up just with a review of some ideas to kind of take home with you as far as the acute abdomen goes. So starting off with the appendix, most likely the most familiar disease that you may have experienced in your casual life. But the appendix, basically, we're not exactly sure of why this thing exists. There's a bunch of different evolutionary biologists that will argue over the original function, or if there ever was even an original function of the appendix. But as of now, doesn't really do anything other than get infected. So it's this small little extension that jumps off of the first part of the large intestine. So again, small intestine runs into the large intestine. Right at that junction, there's this small extension called the appendix. And the main thing that we notice about it is that it's common that it gets infected. This number here, around 7 to 8% of Americans eventually develop appendicitis. Commonly, it does occur in it does occur in the younger age. So any younger population that's experiencing abdominal pain, we certainly want to be aware of appendix. I think the most common age range is between around 10 and 15 years of age. As we can see here, just this tiny little organ causing so much trouble. So inflammation, it can then be followed by infection. Maybe an infection causes the inflammation, doesn't exactly matter. But in general, we have 4 appendectomies per 1,000 children are done annually in the United States. So obviously a reflection of that, 7-8%. And appendicitis tends to be more common in males than in females. So the very, very common presentation for appendicitis would be a 12-year-old boy who comes in complaining of abdominal pain that started out as sort of diffuse and then started to move gradually down towards the lower right-hand quadrant. So just what I described here originally was that we can see these original signs and symptoms of appendicitis being cramping, abdominal pain around the navel, so right around the belly button. Very commonly we have anorexia as well, which is the reduction or the complete absence of the desire to eat any kind of food. Nausea or vomiting can also be associated with appendicitis. As it develops and as it progresses, we commonly see a low-grade fever. It doesn't tend to be 104, 105 degree fever, but absolutely kind of settling in there around 100 degrees. And occasionally, but not as common as the above signs and symptoms, we can see some absence in bowel or urine output. The treatment for us is really going to be rapid recognition, early recognition, and transport to a surgery-capable facility. Appendicitis really isn't something that's treated in any other way than surgery. Nowadays, in a modern hospital, they do it all arthroscopically, so they do it through very, very small incisions, utilizing very non-invasive instruments, and they can extract these things really quickly, pretty easily for the most part, without a lot of complications. So even in an unconfirmed infection, but in a highly suspected case that their symptomology presents in the right way, they will just electively take these things out. So getting them there immediately is important. The main worry with appendicitis, the reason people can die from appendicitis, is a lot similar to what we've already talked about with other abdominal illnesses, and that's that if this thing gets so infected, so inflamed, the tissue becomes so damaged that it causes a perforation. All of a sudden, the contents inside the cecum, inside the large intestine, can start to spill out into the rest of the bloodstream and into the rest of what we call the peritoneal cavity, and they can absolutely become progressively septic and shocky. So again, septic shock is that shock that results from a chronic inflammation and infection of the rest of the body. One nice trick for appendicitis in someone that you suspect, and actually for a couple of other abdominal illnesses, is what we call the heel drop test. And this is specifically a peritoneal sign. So the peritoneal cavity is basically the surrounding membranous tissue that is innervated that the appendix will kind of butt right up against. And so when the peritoneal cavity gets, anything inside the peritoneal cavity gets inflamed, gets infected, it can become an irritant to that area. And to elicit that further, you can simply have the patient stand up on their tippy toes and drop down on their heels. And that little bit of a shock will transmit through, instigating an additional rubbing and a painful response. The other commonly utilized technique is what we call rebound tenderness. And what that essentially involves is a deep palpation of the patient's abdomen and a rapid expansion of the abdomen. So in order to elicit that, you basically will just push nice and deeply with 3 to 4 fingers and rapidly release. Here's just a nice little picture of an arthroscopic, I'm guessing, appendectomy here. Little instrument inside, just taking that guy right out. Next slide here is dealing with our what I alluded to earlier as a very, very dangerous and life-threatening problem, and that is the AAA, or the abdominal aortic aneurysm. So I'm going to go straight forward here for a second. Basically, the best way to describe this thing is an improper ballooning and expansion of what we call our abdominal aorta. So as we've discussed in the cardiac lecture and in the anatomy lecture, our aorta is the largest artery in our body. It's taking the blood straight from the ventricles of our heart to the rest of our body, and it's very, very high pressure. Just downstream of that, as we descend to the lower part of our body where we're taking blood and oxygen and all those other nutrients, we have the abdominal aorta. Still very, very high pressure in this aorta, and as all arteries are composed, we have multiple layers within that structure. And so if there's some sort of minor injury, be it congenital or otherwise, basically those layers can start to separate. And if that very inside layer, as you can imagine on the inside of this artery, starts to fold back, blood is able to pass into that little pocket, but it's not able to continue throughout the rest of the circulation. And so it starts to create this thin area around the aorta, and that creates what we call the aneurysm. Now, when that aneurysm actually explodes, it becomes what we call a dissected aneurysm. And so that's the progress from the development of an aneurysm and an actual dissected aneurysm. The main reason, obviously, why it's such a dangerous situation to be in is that we have a huge amount of pressure through this thing. As soon as it becomes perforated and dissected, all of that blood can rapidly expand into that abdominal cavity, and these people are going to die of shock within literally minutes. So we want to recognize this very early. In terms of some epidemiology, we see that it's most common in men aged between 40 and 70. Also more common in very tall men. In general, any kind of tissue expansion is going to lead to a higher incidence of an aortic aneurysm. So we have rupture, another word for dissection there. We have just our basic list of signs and symptoms. So when we inspect and palpate a patient's abdomen, this person's going to have some severe abdominal pain. Sometimes it can radiate a little bit back. Many times it's described as a tearing pain. As you can imagine, those internal layers of the aorta are torn apart from each other. Abdominal rigidity. Again, rigidity is likely going to be a reflection of that body's mechanism to guard. We're going to clench up our abdominal muscles to hopefully deter any further injury to that area. We start to see now here a very consistent list of what we would expect in a person with shock. And absolutely, as these patients become shocky, our tolerance for evacuation is going to go way down. We need to get these people out immediately. Rapid transport, ABCs, basically supporting signs and symptoms of shock. Only thing ALS can do is try to provide a little bit of fluid resuscitation in the case that this person does become actually hypotensive, but at the end of the day, this person needs to be immediately on an operating table to get this thing repaired. Not a very high survival rate for people that experience abdominal aortic aneurysms, and absolutely if they rupture or dissect outside of the hospital, those chances go even more increasingly down. So finally, just a good review. Really take a moment to learn this slide. I'd love to see you guys be able to reiterate some of these theories and these topics, specifically about what defines an acute abdomen. I'm less worried about you telling me that you think it's pancreatitis versus cholecystitis. I'm more interested in you understanding what abdominal pain becomes severe enough to warrant evacuation and likely surgery, as it was mentioned by this nice little definition we have at the bottom. In general, this is what you saw pretty much on every slide that showed your signs and symptoms and your treatments. Our treatments are always going to focus on our ABCs. Ensuring adequate oxygenation in these people is important. We can do that further by providing O2, good airways, good ventilations. And definitely, let's make a decision. What do we think? Is this person an acute abdomen? We will have a separate video that's not going to be included in this lecture that demonstrates the proper way to assess an abdomen, and that will clue you in on additional tools for how you can correspond your physical assessment to your determination of the severity of this patient and how to make evacuation decisions based on all of that. Definitely be on the lookout for shock as soon as shock starts to develop. And remember, the first signs of shock are not going to be hypotension and massive bleeding. They're going to be tachycardia and tachypnea. So keep an eye out for those two things happening. Think about ILS, ALS intervention primarily for pain management or fluid resuscitation. They're kind of the only tools that we're going to have in these situations to help out as well. So we're going to be thinking very much along the lines of how do we get this patient out of the backcountry and really make those decisions aggressively and early on in the case of a truly acute abdomen. With that, please refer any questions to us that you may have, and I hope you click on the next video, which will likely be the abdominal exam.